Addiction as Chronic Brain Disease. We have Dr. Madhava with us. She is a highly experienced physician currently working as an attending physician at St. John's Riverside Hospital, where she does in-person inpatient evaluation and treatment of substance use disorders. In addition to this, she also has 2 private practices at brainbodymedical.com. And also, Dr. Madhava has extensive experience in areas such as HIV, AIDS, Hep C, and addiction in prisons like Rikers Island. Dr. Madhava earned her MD at Albany Medical College, a Master of Public Health at Johns Hopkins, and a Master in Clinical Research Methods at Albert Einstein College of Medicine. So we really are thrilled to welcome Dr. Madhava. So thank you. And this is a virtual lecture. So thank you so much for joining us.
Yes, thank you for having me, and it's Dr. Madhava. So yeah, as mentioned, I have a lot of experience with addictions, actually several decades. Right after residency, I worked in an opioid treatment program, and since then, I've been working with patients with addictions on and off. As was stated, I also am a primary care doc. I've worked as a primary care doc for a long time and as a HIV/AIDS treating clinician. So today's talk is not all about addictions. It's just one facet of addictions, and it's about what happens to the brain with addictions. And so we're going to talk a lot about the chronic brain disease concept, what happens in the brain, the neurobiology of addiction, and then a bit about addictions and longevity, because there's a conference on aging and increasing longevity. So this is a picture from 1848 by Nathaniel Currier, and it shows the time course of addiction. So this is for someone who's been using alcohol. It starts with step 1, a glass of wine with a friend. And then it progresses to the epitome on top when he's having a jolly good time with cigars and looks like he's having a great time. And then it descends down into poverty, homelessness, and ultimately suicide. And here you see his family in the center, who's very desolate with this time course of addiction, how it devastates the family. And with this in mind, the US government in the 1920s decided to outlaw the use of alcohol. They called it prohibition. And that lasted from 1920 to 1933, basically saying alcohol is ruining families, so let's go ahead and ban it from society. That didn't really work. But even though it didn't work, 40 years later, President Nixon decided to ban other drugs such as cannabis, marijuana, and heroin. So he launched this war on drugs in 1971. So this was really all about punition, getting individuals into the jail system, into the legal system. And this whole framework of the war on drugs was just very punitive. And in this milieu, Dr. Alan Leshner, who was the head of NIDA, in 1997, he sort of said, listen, wait, addiction is a brain disease. It's not a social or a moral problem necessarily. There are actually changes in the brain, and we really need to focus on addiction as a brain disease to really help patients, to help individuals. And in 2019, this is NIDA again, which is the National Institute of Drug Addiction. It's a branch of the National Institutes of Health. And they defined addiction as a chronic relapsing disorder. And it's considered a brain disorder because it involves functional changes to the brain. And they go on to say that addiction is a lot like other diseases, other chronic diseases such as heart disease, diabetes. And so here we have Dr. McClellan in the year 2000 really publishing an article saying we should treat addiction like we do other chronic diseases, like we treat diabetes or high blood pressure or asthma. These are all chronic diseases. So when someone doesn't take their medication when they're diabetic or high blood pressure, and they wind up in the hospital or they wind up with consequences from not taking their medications, we don't somehow reject them from society. We don't punish them. We sort of say, okay, now get back on your horse. Just let's restart treatment. It's really important for you to get compliant with your medications. But what we do with addictions, patients with addictions, is we sort of say, well, you've had your chance. Now we don't know what to do with you. You know, we've tried and tried. So we have a different model for patients who have use disorders. And we're particularly talking about three addictions like cigarettes or alcohol or opioids. So these are the main addictions that have more of a chronic nature to them. And we'll talk more about it as we progress. So this framework of addiction as a chronic brain disease was very important to then subsequently in 2010, where it was mandated by Obamacare, the new insurance paradigm, to cover substance use and addiction treatment as part of regular insurance coverage. And ASAM, which is a society for addiction practitioners, they also call addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and life experiences. And they go on to say that prevention efforts and treatment approaches for addiction are successful, just like other chronic diseases. So as we know, we're not that successful with other chronic diseases, but they were again trying to emphasize that we should treat addiction as a chronic medical disease. And these are some of the reasons why. Here we see a functional brain scan. This is a SPECT scan, a radioisotope scan that looks at blood flow in the brain. So on the left-hand side, you see a normal scan. On the right-hand side, you see this brain that sort of has holes in it. It's not really holes, like if you do a CAT scan, you won't see these holes. These are like functional deficits when a patient is doing a task. Basically, that there is not blood flow in these areas, showing that in this instance, there's a 40-year-old gentleman who's been using opioids for 17 years. After this length of use of drugs, any drugs, you can have functional deficits in the brain. So the brain is not working as well as it should, like a normal person's brain would function. And this is a PET scan that also shows that there's decreased metabolism. And in this instance, it's someone who's been using cocaine for some period of time. And PET scans show metabolism in different parts of the body. In this instance, it's the brain, and it shows decreased brain function in the frontal part of the brain. So this is a cross-section of the brain. And this is an MRI scan of the brain. And here, this is someone who's been using alcohol for a long period of time. And here you can actually see structural changes. So this is an MRI scan. The previous two were functional scans. And this scan, you can see actual shrinkage of the gray and white matter of the brain. So not only do you have functional changes, but in some use disorders, you can have structural changes. And so this is the new terminology for addictions, abuse, dependence is substance use disorders. This came about in 2013 with the new DSM, which is the Diagnostic and Statistical Manual put out by the APA, the American Psychiatric Association periodically. So this was in 2013. And they classify abuse, dependence, all of these categories of substance use into this big framework of substance use disorder. So now we talk about cocaine use disorder or opioid use disorder. We don't really talk about addictions. We can when it's very specific. The name has sort of carried forward. But now we have three categories of substance use disorders. We have mild, moderate, and severe. And that depends on the number of criteria that they meet. So the DSM came up with 11 criteria. And if you meet just 2 to 3 of the criteria, you have mild use disorder. You may have moderate use disorder if you have 4 to 5 criteria, and severe when you meet 6 or more criteria. So the first 4 criteria revolves around your actual use, wanting to cut down, using more than you wanted to. And 5 to 10 is the effect of using the substance has on your relationships in the world, whether it's your work, social life, recreational activities. So you have both, you're wanting to cut down the amount of substance you use and how the substance affects your life. And the last two, 10 and 11, it's about tolerance. So needing more of a substance to get the same effect. That's called tolerance. And physical dependence is when you have withdrawal symptoms. If an individual just has 10 and 11, that doesn't meet the criteria for addiction, because you can have that with many psychotropics. For instance, benzodiazepines. Use of benzodiazepines is not an addiction. We talked about this in my last year's presentation. It's actually a dependence, and also other psychotropics such as SSRIs. So just having tolerance or withdrawal symptoms doesn't make someone have an addiction diagnosis or a substance use disorder diagnosis. And one of the reasons for using the term SUD or substance use disorder is because of the stigma around addictions and some of these other terminology. So here, a study was done by Dr. Kelly. He's one of the lead researchers in recovery and addictions. So he labeled an individual as being a substance user or substance abuser, and the same individual he labeled as having a substance use disorder. And he asked these participants to judge this individual. How do you think that they would do? So what he found out was that these participants felt that the label of a substance abuser, the same individual who was labeled as a substance abuser, they said that this particular individual would be less likely to benefit from treatment, more likely to benefit from punishment. So just labeling as a substance abuser creates more of a stigma for the individual rather than a general term, like it's a non-degrading term, like a substance use disorder. It's much more acceptable and less of a stigma. So that's why it's much better for us to use the term substance use disorder. And often we still have the term addictions for someone who has a very severe substance use disorder. And so we just talked about how substance use affects the brain. And you can see it in different pictures that we take, both functional and structural changes in the brain. Now we're going to talk about the neurobiology of addiction. So this is a sagittal section of a brain. And so this shows the reward pathway. The primary function of the reward pathway is to reinforce behaviors. So you have different parts of the brain. You have the VTA, which is the ventrotegmental area. Then you have the nucleus accumbens, prefrontal cortex, amygdala, and hippocampus. They have different functions within the reward pathway. But the main area of the reward pathway is the nucleus accumbens. So you have dopamine axons originating from the VTA, ending up in the nucleus accumbens. It is felt that the increase in dopamine in the nucleus accumbens is the key criteria, one of the key criteria for the diagnosis of substance use disorder or addiction. And then amygdala registers the emotional aspects of addiction. You have the hippocampus that registers the memory of the experience. And the prefrontal cortex is about concentrating on that experience, focusing on it. And so all of these different areas are very important in the reward pathways. So it's called the mesolimbic. It's also called the mesolimbic pathway. When you look at it a little bit more closely, on the left-hand side is the ventrotegmental area. On the right side is the nucleus accumbens. So these are different cell bodies in these two areas. And this is a picture from Dr. Eric Nestler, 2005. What he shows is that different substances such as opiates, alcohol, nicotine affects these two areas differently. For instance, stimulants directly increase dopamine between the VTA and the nucleus accumbens, basically in the nucleus accumbens, whereas some of these other substances affect this pathway in a different way. For instance, opioids can directly affect the GABA neuron, the interneuron in the VTA, or they can directly affect the the nucleus accumbens. So each drug affects this pathway in a slightly different way. And this is a compilation of studies by Dr. David Nutt. This was published in 2015. And he looked at all the studies which are on the top of the screen. He compiled all these studies that showed the amount of dopamine released in the nucleus accumbens. That's also called the ventral striatum. That's on the y-axis. And the downward bars just show the amount of dopamine released in this area. So you can see in the dark blue, that's IV amphetamine, that consistently increases dopamine in the ventral striatum or the nucleus accumbens. And oral amphetamine also increases dopamine in this area, whereas nicotine inconsistently increases and dopamine, and alcohol also increases. And you see here ketamine. Some people think ketamine can be addictive, and you can see here that it does increase in a couple of the studies that he's compiled, does increase dopamine in the ventral striatum or the nucleus accumbens, whereas morphine here only has a small increase in dopamine in this area. And in this study, what they did is look at the relative effects of dopamine. So I had said earlier that what dopamine does is it rewards certain activities. So the higher the dopamine, it means that particular activity is rewarding. In terms of evolution, it was beneficial for us to go out and seek food. So when we went out and got food and ate food, we had a slight increase in dopamine. So that would cause us to repeat that behavior. So that was good. That was a good thing for us. Just like sex. When we have sex, there's an increase in dopamine. So there's a tonic level of dopamine at about 100. So when you have great food, you have an increase to 150, and sex might be 200. But what these substances do, these addictive substances, is they increase the dopamine to a much higher level. For example, methamphetamines increases the amount of dopamine to such a high level that it sort of overpowers the effect of the dopamine effect that you get from great food or sex. So this is what they mean by hijacking the reward pathway. When we use substances, other aspects of our life that could be rewarding, for example, maybe going to work and getting a praise from our bosses, or perhaps getting a good grade, all of those are overpowered by the amount of dopamine released by some of these drugs. But dopamine is just not a reward neurotransmitter. It has many other functions. As you may know, excess dopamine is one of the root causes of like schizophrenia. There's too much dopamine in certain areas of the brain. And we know that not having enough dopamine in other parts of the brain can lead to Parkinson's disease. And then there are many other functions for dopamine, and it's all listed here. So it's not just the reward and motivation neurotransmitter, and it's not just involved in misuse and addiction. There are many other functions. And besides dopamine, we have many other neurotransmitters, and many of these are also involved in addiction. Even though we talk about dopamine as being the main neurotransmitter for addictions, we'll see a little bit later that many of these are also interact in the brain to affect addictions. So we have adrenaline, which is our stress neurotransmitter. Then we have noradrenaline, more about focus. And then we talk about serotonin as a mood neurotransmitter. And so we have all of these other neurotransmitters. And besides these, we have many, many more. We have probably dozens of neurotransmitters. So what are neurotransmitters? So neurotransmitters are chemical messengers in the brain. So we have about 86 billion neurons in the brain. And how do messages go from one nerve cell to another? So we have this mechanism called neurotransmission, because the cells don't really touch one another. There's a gap between nerve cells in the brain, and that gap is called a synapse. So within the nerve cell, messages go within the nerve cell through depolarization, sodium potassium channels, and that's a neural impulse. That's this. So that's how messages go across within a cell. But between cells, it's these chemical messengers called neurotransmitters that are released at the edge of an axon. And then the dendrite in the following neuron picks up these neurotransmitters and then sends the messages down that particular cell. So here, pardon me, here you have a cell body, you have the axon here, and then messages come down the axon, and then you have the synapse, the gap here, and then it goes down the dendrite here, and then this is the next cell body. So that's how messages go down the cell to the synapse and here. Pardon me, I'm getting over a cold. And so here we have the depolarization, release of neurotransmitters. Messages go forth by these neurotransmitter molecules sitting on the receptor. Each neurotransmitter has a particular message. So let's look at what happens when someone takes cocaine. So this is the same two nerve cells we just discussed. We have the presynaptic nerve cell. This is the nerve cell here. This is the postsynaptic, the one with the receptors. And the presynaptic neurotransmitter gets the neural impulse. It releases the neurotransmitter. In this instance, it's dopamine. It's released into the synapse. And once the dopamine sits in the receptor, you have a message that goes through. And some of the dopamine goes back into the sending cell. These are called transporter proteins. So this is how messages go between nerve cells in the brain. Now, someone takes cocaine, that's in green. So what does cocaine do? What it does is it sits on the transporter proteins. So the neurotransmitters don't go back into the sending cell. So in effect, you have more dopamine in the synapse. So here you have more messaging going forward. So you see two dopamine molecules sitting on the receptor. So this is when the patient will tell you that they feel good. They might even use the word, they're getting high. They feel good with this, with a lot of messages going forward. And here, but the brain itself doesn't like this, right? So when the brain sees that there's too much dopamine, there's a lot of negative effects from having too much dopamine. So the brain downregulates. So what that means is it leads to less, it prefers to have less signaling. So there's less receptors here. So instead of having 4 and 5 receptors here, now the brain downregulates and you only have 2 receptors. You're still taking cocaine. So you have a little bit of more of dopamine here because there's blocking of reuptake, but you only have one message going forward because you have less receptors. This is the time when the patient tells you, I am feeling normal. This drug is not doing anything for me. I'm not getting high. And doctors and people in the general population can't believe that the patient is not getting a benefit from the drug. But this is what's happening in the brain, is that there are less receptors and they're not feeling anything. Sometimes this is also actually what happens with tolerance. So the patient needs more of the drug to get the same effect as in panel 2. Now, what happens in panel 4 is now the patient goes in for treatment, or we ask the patient to stop using the drug. So here you can see that, there's no cocaine. So you can have dopamine going back into the sending cell. And because you don't have enough dopamine here, the patient feels terrible. There's no forwarding signal. So this is when you have patients have withdrawal and craving. They just feel terrible here. They'll tell you, oh, doc, I cannot wake up in the morning. I don't have any energy. I'm just not able to function. So this is where relapse can happen. This is craving. They can have withdrawal symptoms depending on which part of the brain this happens in. So this is why relapse happens, because they don't feel good. This is just not a good place for them to be. So this is the mechanism of for cocaine. This is what happens at the cellular level. And so you can see this in when we do a PET scan. The orange marks, so these are scans of the brain. And you can see here, this is the brain. These are receptors. The orange is are markers for the dopamine D2 receptors. And normal is bright orange, and someone who's been taking cocaine, methamphetamines, alcohol, and heroin, you can see that there are less receptors. It's the mechanism that I just showed you. And so the two hallmarks of addiction, currently believed to be the hallmarks of addiction, is one, that there's a surge of dopamine in the mesolimbic pathway, particularly in the nucleus accumbens. And the second hallmark is that there are changes to the synapse, to the neural circuits. And so these changes are long lasting, these synaptic adaptations that happen. And this is why the behaviors that patients with addictions have last a long time. Because once there are changes at the synaptic and circuit level, it's hard to reverse them. And so what that looks like is, here you have the receptors that we just talked about. And we have second messengers, that protein phosphorylation, which regulate different processes. Some of these are transcription factors that go into the nucleus and they regulate the DNA. And then you have different kinds of neuroadaptations that happen at the epigenetic level. And this creates changes both at the synaptic and the circuit level. And we see that in some of the brain scans that I showed you earlier, the PET scan and the SPECT scan. And Dr. Eric Nestler has been one of the pioneers in looking at the neurobiology of addiction. And he talks about different switches for addiction. And here I'm just mentioning one. There are many, many others. This one is called delta phosphate, that he thought was the molecular switch, but he's found many others. You see an increased amount of delta phosphate in patients who have addictions. And so what we see is that many of the people with addictions, a lot of it is genetic, like the susceptibility to addiction. So some of the changes that I just talked about, some of it are easier for some people because they have these genes that are easily modified. Many genes, so it's not a one-to-one in general. So it's a combination of genetic changes that leads to addiction. They haven't been able to find like one gene causing one addiction. Dr. Kenneth Bloom, another pioneer in using nutrients for addiction, he talks about the reward deficiency syndrome. Basically, what he's saying is that there are a certain percentage of people in the population, about 30% of the population, who have a deficiency of D2 receptors. And if you have a decrease in D2 receptors, you have low dopamine function, resulting in decreased enjoyment in life. And so this can lead to a full range of behaviors that are caused by having low dopamine in different parts of the brain. So both addictive and non-addictive behaviors, such as obsessive compulsive disorders or impulse control disorders. And he goes on to say that we can modify some of these deficiencies through targeted amino acid therapy. And here he talks about different neurotransmitters that are involved in ultimately increasing the amount of dopamine at the end here, the right-hand side bottom, the nucleus accumbens, you have an increase in dopamine. But before that, you have a lot of other neurotransmitters and different areas of the brain being modulated, eventually changing the amount of dopamine in the brain. So this is the brain reward cascade that he discusses. And he's come up with 10 genes that you can measure with a test that would give you a risk score that would tell you if you were more prone to addiction. This would be good for kids of patients with addictions. And what he comes up with is a risk score that you can modulate with the use of some nutrients. We'll talk about it in my next presentation. But there are a lot of other researchers who come up with saying, well, addiction is not just a brain malfunction. There are many other facets of addiction. It's not just that, it's a brain disorder. And, once we correct the brain disorder, the patient is out of addiction, because there are a lot of other factors that we'll talk about shortly that go into someone being prone to addiction. And one of the things that they say is that if someone is given a diagnosis, say, of cancer, or if we give them a big enough incentive, they are able to stop their drug use. So if it was really a brain-based disorder, then they wouldn't be able to stop. Just like you can't will a diabetic to not be a diabetic, they have to make certain changes. But for some patients with addictions, again, we'll see it in the next presentation, they are able to stop by themselves. So this is a complicated slide. So there are many things, there are many factors that go into someone getting into a problem with substance use disorder or an addiction. Today, we just talked about brain mechanisms, but we also just briefly touched on genes and genetic tendencies, but there are many other factors like the biology and genes, and environmental factors are really, really important, especially if someone has had early childhood stress and trauma, and teenage drug use really sets that individual up to get into problems with addiction. So there are many mechanisms for getting into problems with addiction. And it's not just saying that there are brain changes. We have things in the environment that lead us down to using a drug and then having changes in the brain and then eventually getting into the problem of addiction. One thing that no one ever talks about is nutritional status and the availability of nutrients. So that's one of the biggest gaps in treatment of addictions. We'll talk about that shortly. Pardon me. Since this is a conference on longevity, I thought I'd put in a few slides on addiction and longevity. So I can tell you that having any kind of substance use disorder is not good for longevity. It decreases your life expectancy. So in this study, what they looked at was the observed life expectancy over the course of time. This starts in the year 2000 and ends in 2016. You can see that life expectancy was increasing pretty steadily, but around 2014, it started decreasing. And what these authors say is that this decrease in life expectancy was due to drug use. So in the orange line, it's when someone had in their death certificate the cause of death as a substance use, for example, opioid overdose. So that would be drug coded. And the blue line is drug associated, meaning that it could be from, say, overwhelming infection after IV drug use or from liver cirrhosis. So if you didn't have drug use in our population, the increase in life expectancy would be almost 1.4 years. So our life expectancy would have increased 1.4 years for men and 0.7 years for women. So just the effect of drug use in our society is huge. And here, another study just looked specifically at alcohol use and cigarette use, and they looked at a life expectancy across the population. So that was 0. And then what they said was that regular drinkers, more than 1 to 2 drinks per day, their life expectancy was decreased by almost 7 years. If you were a smoker and drinker, life expectancy was decreased by about 10 years. And if you were only smoking, life expectancy was decreased by 2 years. But you did gain life, meaning, using all comers in your life expectancy, that if you were a non-smoker, you gained about 3.97 years. And if you're only a modest drinker, meaning drinking 1 or less drink, there was a protective effect and you gained 0.9 years. And the last 2 years has been devastating in terms of our life expectancy. You can see now a very rapid decrease from 78.8 to 76.1, almost a 2.7 years decrease in life expectancy. And as expected, almost all of it is because of COVID, 50%, you can see this way, And here, 50% of the decrease in life expectancy was due to COVID. But the second biggest decrease was unintentional injuries, almost 16%. And a lot of the suicides are probably related to substance use. So maybe, we can probably use some of that suicide as also unintentional injuries, put it in that bracket. And you can see that unintentional injuries, mainly drug use, caused a decrease of 16% of decreased life expectancy in the last couple of years. So anyway, that's my presentation, and we have lots of time for questions before I go on to my next presentation.
Thank you so very much for that lecture. That was wonderful.
Hi, thank you, Dr. Madhava. That was amazing, and thank you very much for being here, first of all. And I have so many questions for you, so I'm going to limit it to one right now. Have you seen, or do you suspect that there are going to be an opportunity for more rapid neuroplastic changes with the use of psilocybin therapy for addiction?
Funny you say that. I don't know, actually. I don't know the data on that, but I know a couple of my patients are very interested in using that. So I'm going to talk a little bit about I'm going to talk a lot about effective interventions in my next presentation. So I don't particularly touch on psilocybin, but I'm not sure that that's the key to helping our population.
Then maybe I could ask one more. Do we
Yeah.
have more questions? All right, so with using the SPECT scans and the functional imaging of the brain, when you're working with patients, do you ever see underlying psychological diagnoses, like patterns show up as addiction is relieved? Like, for example, if someone has a stimulant use disorder and then that gets resolved and then you see more ADHD-like tendencies?
So I don't actually use a SPECT scan because it costs $4,000. It's very, very expensive.
Okay.
I don't use it, but the AMN clinics do. That scan was from the AMN clinics. And I'll tell you how I treat addictions in my next presentation. So if someone is using stimulants, it's usually because they don't have enough dopamine or norepinephrine. So what we try to do is we boost up the dopamine using nutrients and like omega-3s. So ADHD is in general serotonin and catecholamine issues. So we can, resolve their issues by using some of the neurotransmitter balancing with amino acids and nutrient therapy.
Thank you for that answer. We have a question from our virtual audience. After going through recovery, does the brain tissue heal, repair after subsequent scans?
Yes, and I'll show you a scan in my next presentation. It does actually. Just take some period of time, and it does heal. And that's the good news, right? It's awesome.
Okay, great, thanks. And Dr. Murphy?
Thank you, Dr. Madhava. When it comes to cannabis, does it have the same mechanisms in the nucleus accumbens as far as increasing dopamine at the synapse compared to, say, cocaine or opiates or others?
So what I would say is that it's clear cut for stimulants and all of the other substances. It's not that clear. It's actually controversial, even though NIDA has come out and said this is what it is. Every drug will increase dopamine in the nucleus accumbens. It's really not clear when you look deep into the literature. That one article that I showed you about the different amounts of dopamine, they're actually saying it's not all about dopamine. It's probably a lot of other neurotransmitters, but our focus on dopamine, some would say, is too much, that we don't necessarily always have to implicate dopamine there. And then Dr. Bloom also says that there are many other neurotransmitters that are implicated. So what I do in the practice is when someone has cannabis use disorder, a lot of that has to do with fatty acids and that whole endocannabinoid system. We can try to modulate that. So I'm not sure that it really increases dopamine, and I'm not sure that you need to have an increase of dopamine to have this to have a substance use disorder. It can just be like it's affecting their life, and it could be many other reasons. Maybe it's a cell membrane issue that that needs to be addressed. It's not always a dopamine issue, in other words.
Thank you for that answer.
And one of the things is, sorry, I wanted to, so, like they talk about sedatives as being a use disorder, and I've dug into the literature, and it's not clear that sedatives actually increase dopamine in the nucleus accumbens. And so that's also a little, interesting that, people have just sort of jumped in and sort of said everything is about dopamine increase in the reward pathway.
Thank you. Does the daily use of cannabis in young adults, say in their 20s, cause long-term brain changes?
It can, right? Anything can, even our SSRIs, taking anything consistently will change your brain. And, can we reverse those changes is the question. And I think to a large extent we can.
Thank you. Question from in-house?
Thank you, Dr. Madhava. You may have just answered my question with your last statement, but I'm wondering if you can comment on the prescribing of legitimate stimulants for ADHD and their effect on the dopamine receptors, and whether they downregulate and whether they increase the risk of substance abuse after the use of those, prescribed particularly in very young children.
Yes, I don't think it's a good idea, because I think it does exactly what methamphetamines do. It increases the dopamine, it downregulates the receptors, it makes someone more prone to addiction. So I don't think it's a good idea. I think I think we don't look at our nutritional status and the nutrient status. And, I don't think it's a good idea to give kids stimulants.
Okay, and here's our last question from our virtual audience. Is there proof that patients have psychological changes of the brain compared to control group before substance abuse? If they have family history, they may have been screened, for example.
So what happens with substance use is when a substance meets a person with any, most kind of deficits, the first thing they'll say is, using this substance is like my mother hugging me, right? So for some people, you don't need any psychological changes. It's just the substance meets the right individual, and it's a takeoff from there. I mean, talking to hundreds of people, they will tell you it was such a great moment when I used the drug, and they're always trying to get to that moment when they felt really good, because afterwards you have changes in the brain. But for other people, when you've had stressors in your environment from childhood, that also changes the brain. So that would make you more susceptible to addiction, because you have less optimal functioning of the dopamine because of the stress. You have a lot of changes in the brain once you have stress in your childhood. Stress, abuse, abandonment, neglect, any of those.
Thank you for that answer, Dr. Madhava. So we have one last question.
Madhava.
Oh, Madhava. I apologize.
Yeah. Okay.
Thank you for that. So we will have one last question in-house, and then you can roll right into your addiction as chronic brain disease, the treating addiction part of your talk.
Thank you. So someone had just asked you about stimulants with ADHD, and I was wondering if you had any opinion on clonidine, the use of clonidine, which they're using quite a bit off-label for ADHD. And it seems to have good benefit, especially for sleep as well, if you give it at night.
Yeah, actually, I give patients clonidine, and I have patients who come to me on clonidine. I guess that's a better drug than a stimulant, because, at least I'm tapering someone off of clonidine right now. And he's like, I don't know why I was given this. I was given it for sleep. I've been on it for so long. It's not working. So I'm tapering him off. I mean, if it helps, I think that's better than something else. But I would really, if we can change the conversation in this country to away from medications to looking at other things that could help the individual, I think that would be a better conversation than trying to rely on drugs. But, I belong to a couple of, addiction clubs, and nutrition never comes up. It's always about why can't we discover new drugs? Why are there no new drugs? And, and that's what evidence-based medicine is. It's sort of interesting that they never look at anything else. They just look at drugs. And so, yeah, I mean, I think clonidine could be better. I don't know. I don't take care of kids, but I know patients who come to me, and we actually give clonidine in the inpatient setting when patients are in withdrawal. But yeah.
Thank you so very much for that talk. Let's everyone give a round of applause. And now we're going to roll into the second talk, treating addiction. Thank you.
All right, so this is part 2 of my talk, and this is titled Treating Addiction, an Examination of Effective Interventions. Okay, so here this is the outline, basically talking about the treatment of addiction and successful models of addiction treatment. So what we have in the addiction treatment world is insanity. So this is what Albert Einstein defined as insanity, doing the same thing over and over again and expecting different results. So we talked in my last presentation about this war on drugs that started in 1971, and we still have that, right? Basically, the war is about punition, putting individuals in jail, giving them long sentences, and trying to control drug cartels. And we've been doing that for a long time, 50 years or so. But what we're seeing is that the drug overdose deaths have increased significantly. And this is just from the year 2000. We see that the drug overdose deaths has increased from near 2,000 to almost 110,000. That's a significant increase over just 20 years. And almost all of that is due to opioids. Almost all of that is due to fentanyl. And now we have stimulants coming up. So the insanity of our war on drugs is just incredible. We haven't changed anything. We've actually increased the availability of drugs. And in terms of prevalence, here you can see that with the new definitions from the DSM-5 from the American Psychiatric Association, SAMHSA, the Substance Abuse and Mental Health Services Admin, what they did was they changed their definition to match what the DSM-5 has, and they changed that in 2020. So before, there was a prevalence of addiction of 7.4% of adults in the US over the age of 12. And with using the new definition, we now have a prevalence of 16.5% of the American population as having some kind of substance use disorder. And almost all of it, the vast majority, is alcohol use disorder. And then the other drugs are 24 million versus 29 million. So we see that 46.3 million people in the US have used drugs, and they feel like they have a problem with substances in their life. And so when we look at the breakdown of mild, moderate, and severe, red is severe substance use disorder, you can see that most people with methamphetamine use disorder, almost all of them have the severe type, meaning that it affects every part of their life. Whereas for alcohol, the vast majority see themselves as having a mild use disorder, and a smaller percentage have the severe use disorder, which is addiction. But because you have a bigger number of people with AUDs, you have a higher number of people in the US having problems with alcohol. So in total, what you have is 16 million people who have a problem with addictions in this country. So you have 46 million with a substance use disorder. And if you just look at the severe use disorder, you have about 16 million people. And these are individuals age 12 and above. So what do we do in this country for the treatment of addictions? So we can either treat them as an outpatient or an inpatient. So in the outpatient setting, they might come to each of your clinics and sort of say, you know what, I have a use disorder, can you help me? And many primary care docs don't know how to deal with most addictions. They are not equipped. We haven't taught them. So they may or may not know how to treat addictions. And we'll talk about different medications that are available. Oftentimes, if an individual does come to a primary care physician, they're probably referred out to either social workers or to psychiatrists or to some other referral source. But in terms of medication, what we have for opioid use disorder is methadone. And we'll talk about that in the next couple of slides. But methadone is given in a treatment facility, it cannot be prescribed by a primary care doc. So you have to go to the specialized facility somewhere far away, typically. And they don't have that many methadone facilities across the country. And for you can also perhaps give buprenorphine, which a primary care provider can give, and some of the other medications for alcohol. And then there are always groups, different kinds of, 12-step programs, and there are other programs that are group therapies. And then you have individual therapy that you can have with your therapist. So that's the outpatient. And then in terms of inpatient, when you self-identify as having a problem, what you may do is you can, either you or someone else will choose to go to a hospital and get what we call detoxed. Basically, that means medically supervised withdrawal, where you get decreasing dose of medication over 5 to 10 days. For opioids, we start with typically methadone. We give maybe 40 milligrams of methadone on the first day, then it goes to 30, 20, 25, then 15, 10, 5. So it's a very rapid decrease in the amount of methadone they give. And for alcohol, it's usually a detox with either Librium or Valium. That's also over 5 to 10 days. And even though patients are admitted for benzo detox, patients with benzodiazepine issues should not be admitted into the hospital. Benzodiazepine tapering should be done as an outpatient over a long period of time. I talked about this last year in my last year's presentation. And then after they're finished with this medically supervised withdrawal with medications, they're usually sent to a rehab facility where they're away from their drugs, away from their environment, and they're often given therapy or group sessions. And that can go anywhere from a couple of weeks to a few months, depending on the insurance status and the financial availability for that individual. And some facilities are giving medication-assisted treatment like buprenorphine, or some patients are discharged from the hospital directly to the outpatient setting, again, depending on the insurance and the patient's willingness. But unfortunately, most patients and many providers think that after they go in for detox, this 5 to 10 day period, that they should be cured, that they shouldn't come back into the hospital, that it's the cure. So this is what we talked about earlier. They don't have the chronic disease model. They think that after 5 to 10 days, they should be feeling better and they should not relapse and shouldn't come back into the hospital. Where I work, there are doctors, these are addiction providers who sort of ask the patient, why are you back so quickly? You were just here last month. And so that's that very acute care model. And patients don't necessarily follow up for outpatient therapies. They may not have the right insurance. There might not be places available close to them. But this is the current treatment model for addiction. It hasn't changed much in decades. So we do have this treatment model. What percent of patients access treatment? So according to the SAMHSA survey, and they do that survey every year, this was the results from 2021, only 6.3% of patients who identified as having a substance use problem, only 6.3% actually went in for any sort of treatment, anything that I mentioned in the last slide. So that's about 2 to 3 million people actually went for treatment. And we just said that 16 million people likely had severe substance use disorder, like, not just, and 46 million people had any kind of use disorder. So only 6.3% actually went in for treatment. And why is that? Because the vast majority did not feel like they needed treatment. So almost 40 million people said that they are fine, they don't need any treatment, they can do it on their own. But another 3.2% felt like they needed treatment, but they didn't actually go for treatment. And a lot of that had to do with they did not feel that they could stop the drug that they were using. And some of it had to do with insurance. Some of it had to do with treatment availability in their neighborhood. And other folks said it's because the kind of treatment that they had, that they needed, was not available locally. So there were a lot of barriers to people getting treatment, but the vast majority of people did not even feel like they needed treatment. But one of the positive things about this is in this study that was done and published in 2011, they looked at the natural course of 4 different drugs. And the top one is cocaine in triangular, and then right below that is cannabis, then alcohol and nicotine. What they showed was that for cocaine and cannabis, the vast majority of people actually stopped using it at some point in their life. So if you see 0, 0 as when they started use or dependence, 0, 0, you can see that if you follow that for cocaine, 50% of people had remission by about 5 years or so, like 4 to 5 years, 50% of people stopped, whether they got treatment or didn't get treatment. And there's no medication treatment, and people are not admitted for cocaine use disorder. They may go to rehab, but most of this is outpatient. But 50% of people spontaneously, or they remitted after 4 or 5 years. And virtually 100%, close to 100%, stopped using within 30, 35 years. And for cannabis, something very similar, 50% stopped using at about 6 years, and then many of them stopped using at some point in their life. There was increasing percentage as they got older. But for alcohol, it took a very long time to get to 50% remission, almost, here it looks like 20, 25 years. So people do stop using alcohol, but it takes a very long time. And for cigarettes, it's again, much, much longer. And there are people who die, using alcohol, and they die while while you're still using nicotine. So the remission from using both alcohol and nicotine is there, but it's still, there are many people who continue to use it till till they die, likely. But for cocaine and cannabis, many of the people stop using it at some point. And so this is a chart by Dr. Kelly again. Dr. Kelly does a lot of work on addictions and addiction recovery. And he sort of has this natural timeline of what happens to individuals. And this is all comers, but maybe more around alcohol addiction. Once we have an addiction onset here at this point in time, he said it takes 4 to 5 years before they will even seek help, because they try to do it on their own. They're like, okay, I can do this. They set dates, maybe they they go to groups on their own, but they just try to work out their addiction on their own. And at the end of 5 years, they sort of say, okay, well, I guess I can't stop using. And then for the next 8 years, they try to get help either from physicians, family, self-help groups. And so ultimately, many people are successful. And if you can achieve 1 year of abstinence, then it's likely that you can keep going. And if you can reach 5 years of abstinence, then your relapse risk goes down to 15%. And he says, when you look at all comers, about 60% of individuals eventually attained remission. So this is like all addictions, not just, one. So this is a time course. And that's reflected in the earlier picture that I showed you, where high percentage of people felt like they did not need treatment, perhaps because they were in this area. And these are the different medications and therapies that are recommended by the FDA or by the National Institute of Drug Addiction. So for alcohol, we have disulfiram, acamprosate, or naltrexone. I can tell you that very few providers are actually giving these medications, and these are usually given in the primary care setting. And we have different kinds of therapies like CBT, CM, 12-step programs. And Yeah, very few providers are providing these kinds of medications. The effectiveness is also not clear, whether how effective they are. Naltrexone can be given in instead of giving it twice a day, we can give naltrexone an hour before someone goes drinking. It's called the Sinclair protocol. 50 to 100 milligrams an hour before someone goes drinking. For some individuals, that's been found to sort of curtail their drinking because it takes away the reward aspects of drinking. So that's one way we can give naltrexone. For nicotine, it's much more widely prescribed when we have all of these two medications and nicotine replacement. And for opioids, I mentioned earlier methadone. Methadone is very effective, but it's only available in these specialized treatment centers. And the number of these treatment centers hasn't significantly increased because of a lot of community and state and federal sort of barriers. No one wants to have a methadone treatment program in their community. But buprenorphine is available. Primary care providers can prescribe it. It's a partial agonist at the receptor site, so a lot of patients don't necessarily like buprenorphine. They like it because it can be provided at the primary care setting, whereas methadone is much more difficult. You have to go to this program, and the specialized program, you have to go every day for 90 days. And it's not, I've worked in OTPs, I've worked in several OTPs. Many patients don't necessarily like it. And a lot of patients actually feel that this is just a substitution treatment, that they're not really getting cured from addiction. So many patients who come into the methadone program or the OTP, they sort of say, when can I get off? I'm ready to come off. They come in and they want to come off. So these medications, like the alcohol treatment medications, is not widely prescribed. The effectiveness is not, I'm not sure if it's great. Nicotine, I think it's much better, nicotine dependence treatment. And for opioids, so methadone, buprenorphine are actually really good because they actually prevent death, and we'll talk about that shortly. And these therapies are somewhat effective, but we give them usually with medications, but it's often given independently. And we don't really have any medication treatment for cocaine, marijuana, benzos, or amphetamines. Benzos, we should probably do a slow taper over a long period of time. And there's no FDA, NIDA approved medications for cannabis or for cocaine. And if you look at the effectiveness of these treatments, this was a study done in a clinic in Connecticut affiliated with Yale. They got standard of care treatment, medications, therapies, everything, like the full works, for a year. And what they found was that at the end of 1 year, there were still only 25 to about 30% of patients were abstinent. After getting state-of-the-art therapy, the only 30% were abstinent at the end of 1 year. So you can see that what we're doing is not necessarily effective. So this is where part of the insanity comes in. We've been doing the same thing for decades, and this is what we get, because about 50 years prior, this is 1971, when they looked at relapse rates, it was the same relapse rate, somewhere between 20 to 30% of patients relapsed at the end of or at the end of 1 year. Only 30% were abstinent. So the rest probably relapsed during that period of time. So nothing has changed over 60, 70 years. What we're doing is not really that effective. It's somewhat effective, but it's really not that effective. But as I said before, medication-assisted treatment for opioid use really can work. It can decrease the overdose deaths that we have. I just showed you earlier that there were about 100,000 deaths per year due to opioid overdose. So if we can give them methadone or buprenorphine, the red line is the number of deaths. So you can see that overdose deaths do decrease as we increase the availability of methadone. The dotted line on top is methadone, and then the bottom line is buprenorphine. And buprenorphine only became available in 2002. And you can see that the death rates have come down. But what do we actually do? So this was a study done in Massachusetts. They looked at 17,500 patients who actually had near death from opioid overdose. So they were rescued with Narcan or some other, usually the Narcan. So they did not die following an opioid overdose. So they followed these patients through different databases. What they found was that only 30% of patients who nearly died from opioid overdose, only 30% were given these medications that would have perhaps helped them avoid another overdose. And the median duration of this treatment was less than 6 months. So the patients did not stay on treatment. And then this is the insanity. 34% of these patients who had near death, they were prescribed opioids again, usually for pain. And then another 26% were prescribed benzodiazepines. So benzodiazepines and opioids together, they increase the risk of death tenfold. So you really shouldn't use opioids and benzos together. But yet, here you have someone who died, nearly died, did not die, nearly died. They were rescued, and yet they were prescribed both opioids and benzos. And unfortunately, in the following 12 months, 368 patients died of an opioid overdose. So this is the insanity, right? We have medications that can potentially prevent overdose. We know these patients actually had an overdose episode, and yet, we still having these kinds of overdose deaths and the kinds of prescriptions that we should really not be giving patients who had near-death experiences. So let's talk about some successful models of addiction treatment that we as a society can actually, or as physicians, we can enact for ourselves. So Portugal. Portugal is a country in Europe. It's highlighted in red here. So they had a really severe problem with drug overdose deaths and HIV/AIDS because they were using needles, and at that time, patients were repeatedly using needles and sharing needles. So they had a lot of HIV and drug-related overdoses. And so what they decided in 2001 is to decriminalize all drugs. So if you had a certain amount of drugs, you were not taken to jail. You was fine. You were given easy access to medication. You remember how I told you that in America, you have to go somewhere, sometimes drive an hour, hour and a half to get methadone, if they even have it. But here, what they did was they would have buses going to the patient's residents to give them medications. So at that time, it was methadone. And they had needle exchange programs. They had increased funding for rehab and jobs programs. So they had this comprehensive programs for patients so that trying to decrease the problems that they had seen in their society. And what happened with that is that they had a dramatic reduction in the rates of continuing drug use. It went down from about 41% down to less than 30%. And the overdose deaths in 1999 was 369, and they enacted this program in 2001. By 2016, the number of overdose deaths came down to 30. HIV diagnosis went from 907 to 18, and drug offenses went down by more than a third. And then if you look at comparative data in 2017, you can see here in Portugal, there were 6 deaths per million related to drug-induced deaths, drug overdose deaths, 6 per million. In the US in 2017, and the problem has increased significantly since then. I showed you that data, and it was 185 per million. So this is potentially something that our society can do. We can decriminalize drug possession a small amount, and we can get so many benefits from doing this. And then another program that has been successful is with pilots and physicians. So when a physician is noted to have a problem with drug use, either because they were reported by colleagues or because of the hospital or somewhere else, when they're noted to have a problem with drug use, they're put into this specialized program. where they go inpatient for about 90 days, and then they're followed for about 5 years. They get random urine checks. They might get random visits from from this program. They have access to therapists. So with all of this kind of comprehensive outpatient care, you see that 78% of physicians at the end of 5 years are working and are licensed to work. So this is pretty successful, but it's a very comprehensive program. So we've talked about this before, that if you're abstinent for less than 1 year, you have a very high risk of relapse. But if you can make it to 5 years of abstinence, you only have a 14% chance of relapse. And if you can make it to 15 years of not using, then your risk of getting back into problems with substance use is very, very low. It's the background like we have in the population. So it's very low. The longer you're not using, the better chances you are of not relapsing. Pardon me. So we never talk about nutrition. It's not taught in MD medical schools. So it's as if it's a blank slate here. There's nothing about nutrition, but we know that there's a lot of success with nutritional approaches. And there are hundreds of studies. If anyone wants to know more, feel free to email me, but I'm just going to go through a few studies here. But there are a lot of studies to show that if we can focus on nutrition for our patients, that they are able to get better and they're able to be abstinent. I'm just going to go through a few studies. So this was something published in 1955, Nutrition as a Factor Against Addiction. This is a paper by Dr. Bloom, and he's the one that talked about the reward deficiency syndrome in my last presentation. He developed a nutritional compound, and this was in the 1980s. And he gave it to patients with cocaine use disorder. And what he found was that giving it to these patients, less patients signed out AMA. They were able to stay in treatment and do all the therapies that they needed to do just by giving a bunch of nutrients. And here he did a double-blind control study, and this is for severe alcoholism. He gave them phenylalanine, tryptophan, glutamine, and P5P. And what he found was that this is a double-blind control study, that those patients that got these nutrients, they did much better. They had less desire to drink and less withdrawal symptoms. And these are the nutrients that he uses, and I use the similar nutrients. D-phenylalanine is for increasing the amount of opioids in your system, and L-phenylalanine is a precursor to dopamine, tryptophan, and 5-HTP is for serotonin, tyrosine is for dopamine, and so on. And this was a study by another pioneer in the use of nutrients for addictions. It's Joan Matthews Larson. She has a book called 7 Weeks to Sobriety. And what she did was she gave this a group of patients a very extensive amount of nutrients for their alcohol use disorder. And what she found, she only treated them for 6 weeks. And what she found was that they were abstinent for a year and even more than a year, just giving patients a group of nutrients to increase the neurotransmitters in the brain. So basically what you're doing with nutrition is you're giving the brain the nutrients it needs to make the neurotransmitters, to make the serotonin, the dopamine, all of the different neurotransmitters it needs. And with that, the brain is able to function better. And when you have a functioning brain, you're able to go to therapy, you're able to interact with your family. So it's very important to get the brain to function better. And here's another inpatient study that was done in New York. And here what Dr. Beasley did was he followed patients who came into the inpatient ward for detox. These were severe alcoholics who would have had multiple admissions. And he actually measured their nutrient levels. And he found that about 80% of the population were malnourished. They had specific nutrient deficiencies. And he also gave them some nutrients, gave them therapy. So they had 1 month inpatient detox and rehab, and then they had a year follow-up. And 67%, 67 subjects, or 60%, were abstinent at the end of 1 year. So this is also a very successful program. And so basically, a well-fed brain is a happy brain, because you want to give the brain everything that it needs. The brain needs nutrients. It needs nutrients to make the neurotransmitters. It needs nutrients for the cell membranes. So if we can get the brain to function better with good nutrition, there's a good chance that we can really help the individual. And we can also prevent addiction. Like if someone has good nutrient status, in the teenage years and their youth, then we can prevent them from getting into problems with addiction. And so this is what we see, right? A healthy person has a lot of D2 receptors here, and then 1 month abstinence, they are still not recovering. And once they are away from drugs for some period of time, what we see is recovery of their brain. So the brain does come back for, depending on the amount of time you've been using, the brain eventually recovers. So I talked a lot about my practice last year, but I'll briefly talk about it. So I basically look at brain repair. I do a lot of the nutrient therapies that we just talked about, and then I refer them out for psychological, social, and spiritual. So patients need to have all the biopsycho, social, spiritual model. They really need to do all four factors. All of these are very important for recovery. So the patients do all four things to recover. And this is, I use this chart all the time. It's looking at the symptoms and then mapping out to certain nutrient deficiencies. So low serotonin can give you certain symptoms. And if patients have those symptoms, if they report those symptoms, and then I give certain nutrients to try to increase the serotonin or the catecholamines or the GABA. And so these are some of the root cause of addictions. I don't, we can do, can do testing. I don't necessarily do testing for everyone. It depends on their resources, but I do the amino acid chart, and then I do give them nutrients for treatment. And lessons from the HIV epidemic. So I worked in a HIV/AIDS clinic for a long time. Actually tried to bring methadone treatment into the HIV clinic, but of course that didn't work because methadone is one of the most highly regulated drugs in this country. So what we did for HIV, the first people who got HIV was the gay population. So they were very, very politically active. I don't know if anyone remembers, but they had a lot of ACT UP groups. They would disturb a lot of meetings that politicians were there. So they created a lot of ruckus. And with that, they got a commitment from the government to funding HIV/AIDS treatment and prevention. So I worked in New York City, and I still work in New York City. And so this is a graph of what happened. So we started tracking HIV in 2000. You can see that the black line, you can see that HIV has come down significantly. It's increased in the last 2 years because of the COVID epidemic. And there's, it shows that we really need close follow-up and of these patients. So anyways, and then you can see here, new AIDS drugs were discovered. And with that, again, new AIDS diagnosis pretty much decreased. So HIV is the infection and AIDS is a diagnosis. So if you had a CD4 count of less than 200, you were considered as having AIDS or any of the opportunistic infections. So HIV is the infection. So once you started giving medications, as soon as someone got HIV, you prevented them from getting into this definition of AIDS. So that's why AIDS has actually gone down pretty significantly. And so, of course, the number of people who are living with AIDS is pretty high. So this was an effort at all levels. So once they got the funding, the commitment from the government, so patients with HIV in New York got housing, they were automatically considered disabled. So they got, health insurance, Medicare, and they got some amount of weekly or monthly allowance, and they got all access to all of this healthcare. And so at every level of government, they had certain goals. So at the federal level, this was a 2019 goal. Their goal was to reduce HIV by 75% and then 90% reduction in 10 years. And this is the way they were going to do it, like diagnose, treat, protect, respond, and HIV health force. So they had a goal and they had mechanisms of how to achieve that goal. And that was at the federal level. At the New York City level and at the state level, each of these, at the state level, they had their own goals. At the city level, they had their own goals. At the community level, they had goals. And at the clinic level, we had goals. So everyone was focused on how to reduce HIV and how to contain the HIV infection. And they had funding for it. So if we can do the same thing, if we can use that same model for many of our chronic diseases, especially for drug addiction, then I think we would make great progress. I've showed you several different successful programs, including, national, what Portugal did or what we did with HIV. If we can do the same thing for drug addiction treatment, I think we would make great strides. And as Dr. Leshner said in 2007, he said, we will only make progress in dealing with drug issues only when our national discourse and our strategies are as complex and comprehensive as the problem itself. I don't think we're there yet, but that's our hope. And this is one of my friends, he made this chart. So to prevent addictions, we can do certain things, including diet, monitoring a child that has addiction in the family, then lots of things to repair. Once you have addiction, you have a lot more things that you need to repair. And then how do we help them live beyond a life of addictions? All right, thank you. If anyone wants to know more about nutrition and addiction, feel free to email me.
What an important topic. Thank you so much for sharing your knowledge and wisdom with us today. We really appreciate it. Have you ever looked into studies showing correlation between mothers who get epidurals for labor and increased risk of addiction later in life?
I haven't looked at that particularly, but I can say that, if the mother doesn't have good nutrition when she has the baby, that can increase the chances that the child will have problems. And it can, so many different problems can arise from a mom not having good nutritional status when she is pregnant with a child.
Since cannabis works on GABA receptors, does taking GABA help it or make it worse for cannabis addiction?
I don't know about that. GABA or cannabis? Actually, I don't know about that.
Okay, thank you. What dose of NAC for cannabis or cane addiction?
For cocaine, actually, I give NAC pretty much for a lot of the addictions because it's actually anti-inflammatory in the brain. And I go pretty high, it's really high, like 4 grams. Because what happens is these drugs can cause inflammation. And so we would want to decrease the inflammation with NAC. But for cocaine, what you're going to do is give tyrosine, high doses of tyrosine. Tyrosine is great for both cocaine and for amphetamines. So you give tyrosine and omega-3s, those are the nutrient treatments for the stimulant addictions.
Hello. Yes, my question is related to NAC also. I'm just curious about the mechanism of action on NAC with nutritional intervention.
So as I said, NAC is anti-inflammatory. So what happens I think this is one of the mechanisms, is when there's inflammation in the brain, you can have increased glutamate. Glutamate can be it's an excitotoxin. And NAC has cysteine. Apparently the cysteine and the glutamate are, they have a co-transporter. So glutamate goes out of the system and cysteine comes in that co-transporter. That's my understanding of how it works. And glutamate is that excitotoxin that we have in the brain that can, be related to many, many things, many addictions.
Okay, our last question virtually. Do you know the stats for outpatient detox versus inpatient?
What do you mean? There's no inpatient detox. Inpatient detox. Okay. So inpatient detox is just 5 to 10 days. It's not even, it's not very helpful for a long-term treatment. It's just to make the brain feel better. And I can tell you 5 to 10 days is really not enough for the majority of patients, because many patients are coming in using fentanyl, which is very, very strong. And when we're giving 40 milligrams of methadone, it actually doesn't make a big dent for many patients because they've been using so much. If you're using less, then that's effective. What we're doing in the inpatient detox setting is just making the brain feel a little bit better, and it doesn't really deal with the issue of addiction. That is really a long-term problem, and that something that needs to be addressed in the long term. And so the patient needs to go to the outpatient setting, get medications over the long term. So we're not really treating an addiction in the inpatient setting. We're just helping them with their symptoms for a short period of time so they can feel better as they continue treatment in the outpatient setting. Not everyone needs to come in for inpatient detox. They can just go directly. For opioids, I really don't think we should be admitting them to an inpatient detox facility, because we rapidly taper them from 40 milligrams to 0 in 5 days. They feel miserable. In fact, what they need is to go to an outpatient methadone program, stay on a high dose, 40, 50, 60, 80, and then slowly come down over some period of time, not 5 days, 10 days, but maybe weeks to months.
Thank you. And now our last question in-house, just a quick question.
I'll try. This is regarding, thank you, Dr. Madhava. This is regarding the genetic testing. Are you doing it on every patient? Do you get insurance to cover that? And how often are you seeing genetic SNPs, particularly MTHFR and COMT, which will be modified with nutrients and dietary changes?
Actually, I don't do any genetic testing. Most of what I do is just the neurotransmitter depletion chart, and I work with that. And what I do is blood testing that's covered by insurance like Quest or LabCorp, and then I will see if they have folate B12 deficiency. Sometimes I'll do an oats test. I don't necessarily do the GARS test because the GARS test actually is not that available, and I haven't been doing it at all, actually. So I usually do blood testing, and then if they want more, do oats testing. Many people really can't afford the testing, and I try to work with, with the questionnaire that I have.
Thank you so much. And once again, thank you so much for sharing with us today. Thanks again.
Thanks for having me, and feel free to email me if anyone wants more information.
Thank you.